He's probably enjoying his first cup of coffee.
Probably.
Hi, Datta.
Hi, Sangeeta.
Hi. Hello, Dr. Dev Pujari.
Welcome, Sangeeta.
How are you?
Everybody is fine, but not fine.
Sangeeta and Rajesh are our neurology colleagues. Rick, I don't know if you have ever had a chance to meet them. Have you introduced Datta?
No, I have not introduced.
Sangeeta mainly does adult and children, and Rajesh does mainly children.
Hi, good evening, sir. Respected sir. Session will begin next 1 minute.
Yes.
Just after the countdown of 5.
Yeah. Sir, I will start and then ask you to moderate.
Okay.
Yeah. Welcome to the BNA pre-conference workshop, and this is the second workshop on pediatric epilepsy surgery, and we have our vibrant faculty today with Professor Dev Pujari moderating the session, and on our panel are Professor Rajesh Udani from Hinduja Hospital and Professor Sangeeta Rawat from KEM Hospital. Our distinguished panel of guests include Professor Rick Boop, who is the Professor of Neurosurgery in St. Jude's, Memphis, Tennessee. And he has got extensive experience and is a well-known figure in epilepsy surgery as well as in neuro-oncology. Professor Jeffrey Blount is the second speaker, who is from the Birmingham, Alabama. He is also a renowned figure in epilepsy surgery. And we will, for the next 1 hour, we will enjoy their talks and have a good discussion. Over to you, Professor Dev Pujari. We can start the session.
Thanks, Datta. I'm sure that you will enjoy the next 1 hour session on pediatric epilepsy surgery. And without much further ado, I would ask Dr. Boop to start his talk on hemispheric epilepsy.
Can I have the screen, please? I'm not seeing my slides yet.
Yeah, can you share screen? Professor Boop, you have to share screen. It went off the screen, actually.
All right, there we go.
His presentation was already there on this.
Yes.
I say, Chandrasekhar, I hardly recognize you without the beard.
Yeah.
Well, thank you, everyone. It's an honor to be able to present to you today. What I've planned to do is just give you an overview of the different techniques that have been developed throughout the history of epilepsy surgery for treating hemispherical disorders and give you some personal thoughts on it. Let me start out by saying that when we do resective surgery for epilepsy, it gives us access to tissue for research that we don't really have with any other surgery outside of brain tumor surgery. And so when you take out a lobe, or particularly when you take out a hemisphere, having collaborations with your basic science researchers gives them tremendous opportunities to grow neural stem cells, to look at vascular studies from Peel vessels, et cetera. And one of the most exciting things in my career has been the ability to send epilepsy tissue to the basic science labs and all of the tremendous research and grants that have come out of the use of that tissue. So for young neurosurgeons, if you're doing epilepsy surgery, this is a tremendous way to further your career and to gain insights. So when we look at the history of hemispherical disconnections, it's interesting, back in 1928, Walter Dandy was one of the first to try hemispherectomy, and he was trying it as a treatment for glioblastoma. And he thought that if he isolated the hemisphere, then the cancer couldn't spread. Perhaps he could come up with a way to cure this horrible neoplastic disease. But when doing so, he made the observation that in patients who had terrible seizures from their tumor, that their seizures got better when he isolated the hemisphere. He found out that it was not a cure for glioblastoma and abandoned it for that purpose. But that was where we first began to understand that hemispherectomy might be an opportunity to treat patients who had hemispherical disease. And it was in 1938, actually, that Kreinow started doing hemispherectomy for infantile hemiplegia. And this is his publication, Infantile Hemiplegia Treated by Removing One Cerebral Hemisphere. For those of you who are interested, this publication is available for free through PubMed. So the indications for hemispherical disconnection basically are intractable seizures emanating from one hemisphere in a hemisphere that is not particularly functional. And I say that because I was at an epilepsy conference one time where a normal patient with temporal lobe epilepsy failed a temporal lobectomy, and the center went on to perform a hemispherectomy in that patient. And that has bothered me ever since. That's not typically where we would consider doing a hemispherectomy. But typically for perinatal MCA stroke, non-accidental trauma, Rasmussen's encephalitis, Sturge-Weber syndrome, Hemimegalyncephaly, gyrational disorders, and sometimes for gliomatosis cerebri, if it hasn't crossed the corpus callosum, then we'll consider hemispherectomy. So here's a case, an 8-year-old female with a history of non-accidental trauma at the first year of life, infarction of the left middle cerebral and anterior cerebral vascular distributions with subarachnoid hemorrhage, subsequent onset of seizures with secondary generalization and frequent falls. She'd had multiple injuries. And here you can see her MRI showing the gliosis along here, the loss of volume in the MCA distribution and the frontal distribution, but relatively well-preserved right hemisphere. And you can see here the onset of her seizures by video telemetry were all isolated to the left hemisphere. And at surgery, this is frontal, this is occipital, temporal lobe here, Sylvian fissure here. And you can see the gliosis up here and the atrophic gyri in the posterior frontal lobe here compared to the normal gyri occipitally. We traditionally have placed grids over the hemisphere with strips under the temporal lobes, and then a standard Rasmussen or Montreal hemispherectomy, where we perform a temporal lobectomy, a frontal topectomy, and then disconnect the occipital lobes and the frontal lobes, as you see here. And she's gone on to have improved seizure control. She still has occasional complex partial events, but has quit injuring herself with this hemispherectomy. So the approach to pre-surgical evaluation of these patients has become fairly standardized. A phase 1 approach is patients who failed medical therapy and go on to a non-invasive pre-surgical evaluation. The mainstay of this is good neuroimaging and 24-hour video EEG monitoring to evaluate where the seizures come from, detailed neuropsychometric evaluation, ictal, SPECT, PET, MEG. SysCom is a subtraction of ictal from interictal SPECT that can oftentimes give us very good information about the ictal onset zone. And then phase 2 is invasive monitoring used in some patients, not all patients. And then phase 3 is surgical resection. We have a MEG paradigm for language that we've been able to implement in infants down to 1 year of age that looks at localization of propofol or Versed in the MEG unit, and then the computer generates words at 80 decibels through earbuds while the patients are asleep in the MEG, and the MEG can show us where the Wernicke's area is, even down to an age before language is fully developed. And so in this next case, it's a child with a classic MCA congenital infarction of the left hemisphere, but fairly normal speech. And when we recommended hemispherectomy, mother said, well, how do you know that you're not going to ruin her speech if you disconnect the left hemisphere? And so you can see here is her MEG. All of her language responses are here. All of her periictal areas on the MEG are right around the porencephaly. And we're very comfortable then going on to hemispherotomy, as you see here. And this is her MRI the day after surgery, showing good disconnection and no ill effects on her language. So there are 5 modifications of hemispherectomy that I'll review. The classic is anatomical hemispherectomy that has since been abandoned. The Adams modification, Dr. Adams was in London. Functional hemispherectomy, Hemi Decortication, and hemispherotomy. And then I'll talk about a temporal occipital parietal sectioning that we use on some occasions that can spare a functional frontal lobe in some cases. So classic hemispherectomy starts with a temporal lobectomy and then clipping of the anterior cerebral, the distal M2, and then the posterior cerebral where it comes over the tentorium. And once the hemisphere has lost its arterial supply, then going on to remove the hemisphere. And this is what the scan looks like after an anatomical hemispherectomy. As you know, this has been abandoned because of a late complication called superficial hemosiderosis, which is almost like chronic subdural membranes that develop over this large empty hemisphere. And onset median time to recognition of superficial hemosiderosis is almost a decade after surgery. But once it develops, these patients develop hydrocephalus, and despite multiple operations, it's a very difficult condition to treat. That's why this was abandoned back in the 50s and 60s. So Adams modification is a plication in which the dura is sutured to the inferior edge of the falx and to the tentorial edge, and then temporalis muscle is used to plug the foramen of Monroe in an effort to make the intradural space smaller and to prevent superficial hemosiderosis. So the dura is tacked here and here, muscle is placed here, and the trade-off is a large epidural space rather than a large subdural space. I can tell you that I've done this one time and would never do it again. The patients go on to bleed into the epidural space, and there's nothing to prevent compression of the dura along this area, midline shift, and it's not a good solution to the problem. So after trying this once, I would not recommend it. Functional hemispherectomy, the Rasmussen technique developed and promulgated by Delalande and Villemure at Montreal, is a temporal lobectomy followed by a frontal topectomy to get access to the ventricle, and then the insula is removed by suction. And in this case, it's important to maintain the arterial supply to the frontal and occipital lobes. Otherwise, they may infarct, and then you're back to an anatomical hemispherectomy once those infarcted lobes go on to liquefy. So this is a picture of the classic Montreal functional hemispherectomy. You can see the frontal topectomy here, the temporal lobectomy here, and then disconnection of the occipital and frontal lobes through the insula. Hemi decortication was first described by Harold Hoffman at Sick Kids back in the 70s. And this is using the ultrasonic aspirator to basically remove the cortex down to the periinsular or the periventricular white matter. And he used this primarily for children with hemimegalyncephaly or Sturge-Weber, leaving the ventricle isolated with the white matter intact over the ventricle. And he thought that this was a good way to reduce the incidence of post-resection hydrocephalus, which occurs in 20 to 25% of children undergoing hemispherectomy. So here's a picture of a classic hemimegalyncephaly. You can see the large dysplastic ventricle, the thickened cortical ribbon associated with migrational disorder. And when you look at this under the microscope, you'll see clusters of neurons that are stuck in the white matter, periventricular white matter, that never made it out to the surface of the neocortex. And that's probably contributes to the lessened success rate that we have with these children compared to others who have a normal brain with an insult on top of it, such as this patient with Rasmussen's encephalitis, where you have progressive cortical atrophy associated with intractable epilepsy, and again involving one hemisphere. And I'll say I've always been intrigued by our current model of embryogenesis of the diencephalon, and how it is that with diseases such as hemimegalyncephaly and Rasmussen's encephalitis, we can have one normal hemisphere and one abnormal hemisphere. Doesn't quite fit with the classic embryogenesis model that we have of a flat sheet of neuroectoderm that rolls up into a neural tube. Hemispherectomy was first popularized by Delalande, and then Schramm modified this to a periinsular hemispherectomy, working through an open sylvian fissure. The advantage of this is less time, less blood loss, smaller craniotomy. And this is sort of an inside-outside functional hemispherectomy in which the sylvian fissure is opened. This is their paper in which they reported their periinsular hemispherectomy. The sylvian fissure is opened widely, and the ventricular is entered through the circular sulcus. The insular tissue is removed by suction, as are the mesial temporal structures, and then one can follow the tentorial edge around the incisura and undercut the white matter tracts up to the falx, and then find the distal pericallosal arteries and undercut the white matter tracts from within the ventricle, following the pericallosals forward and around the genu of the corpus callosum, and then undercutting the white matter of the frontal lobe as you follow the MCA out. And that disconnects the hemisphere. Again, when you're not removing much tissue, particularly in big hemispheres like hemimegalyncephaly, it's important to preserve the blood supply to the occipital or frontal lobes, because if they infarct and swell, there have been cases of these patients getting into trouble from mass effect from the swollen infarcted tissue. And that's one of the reasons I like the standard Montreal hemispherectomy, where you do a frontal topectomy and a temporal lobectomy. And that way, if you have an infarct and you have some swelling, you've got enough space that the patients don't get into trouble from it. But with this technique, the mean operating time was 3.5 hours. The blood loss and the need for transfusion was much less, and the outcome was quite good. And I'll point out that the outcome, as with all epilepsy surgery, is related to how you choose your patients for surgery. So here's a case of a patient who was born by cesarean section prematurely, had an asymmetric motor exam at birth that was initially thought to be a shoulder dystocia, brachial plexus injury, until at 2 months of age he began seizing. At that point, went on to have an MRI scan demonstrating a congenital MCA infarct, as you see here, loss of volume in this hemisphere. And with the intractable epilepsy, then went on to phase 1, phase 2 evaluation and hemispherectomy. So a couple of decades ago, Holthausen published a book on the epilepsies that was a compendium of all of the major epilepsy centers in the world, putting together their data and looking at outcomes. And this is one of the larger series on outcomes from hemispherectomy. And what you might expect is that the outcomes are best in patients who have a normal hemisphere with a superimposed abnormal cortex or injury such as Sturge-Weber or the congenital MCA infarct. And in such cases, between 75% and 85% of patients will be seizure-free. When you look at the malformations, the overgrowth syndromes such as Hemimegalyncephaly or polymicrogyria, the results aren't nearly as good, but still significant enough that they can certainly improve the quality of life in these patients. In this series, they also looked at the different techniques, and as you might suspect, the hemispherotomy had some of the best results. Anatomical and Hemi Decortications, which were typically done for migrational disorders, did not have as good a results. And that relates again to the substrate that you're operating on rather than the technique in my mind. But 328 patients pooled here is one of the largest series looking at outcomes from this type of surgery. And then let me finish up by talking a little bit about what we call TOPS, or temporo-occipital-parietal surgery, trying to spare function in a frontal lobe in patients that have a fairly normal frontal lobe. And this is a good reference here from Montreal, looking at the various techniques. In this paper, they pooled data from Montreal, Lausanne, and Valour. And you can see that it's not a very common procedure. In 15 years, these 3 large epilepsy centers had 13 patients. When they looked at their seizure disorders, 4 had poor encephaly, 3 had atrophy, 1 was an AVM, 2 Sturge-Weber, 3 with cortical dysplasia. All of them, as you'd expect, would have a homonymous hemianopsia, but the idea is if you can spare posterior frontal lobe, you can give the patient improved motor function by sparing the motor strip and, if possible, the postcentral gyrus as well. And in properly selected patients, the Engel outcome is quite good. So they describe an anatomical posterior quadrantectomy. I'll show you an example of that. Functional posterior quadrantectomy and a periinsular posterior quadrantectomy. The case I'm going to show is an anatomical resection. I've done one of those and since have done several disconnections through this same approach. But it involves disconnecting the temporal lobe, the occipital lobe, and the parietal lobe, performing a callosotomy in the posterior portion of the corpus callosum and sparing frontal lobe function, as you can see here. And this is the quadrantectomy, disconnecting through the sylvian fissure and then up through the either central sulcus or post-central sulcus. So this is a case of a 6-year-old who came in with complex partial seizures, right-sided body semiology, multiple seizures per day, had to wear a helmet because of contusions and lacerations from his falls. And as you can see from his MRI here, polymicrogyria and a schizencephaly in the posterior frontal lobe, not completely normal frontal lobe here, still a bit dysplastic, but not bad. But when we looked at his seizures, they tended to come from the parietal occipital region and the temporal region. Here's his MEG study, and here's the interictal abnormalities from temporal lobe and parietal lobe. And seizure onset from the scalp, as you can see here. So here's his ictal semiology. In phase 1, this is just scalp recording. And you'll see motionless stare here, followed by dystonic posturing of the right arm and leg. automatisms of his left arm. And then as it progresses, he'll get some drawing up of the right side of the face, classic right body, left hemisphere seizure. Here's his brain. This is frontal here, occipital, Sylvian fissure here. And you can see all the polymicrogyria and even what looked like exposed ependema over what should have been occipital cortex. So broad invasive coverage with depth with subdural electrodes. Nowadays, we would probably do this with stereo EEG rather than with subdural grids. But you can see his ictal onset here is all in that same hemisphere. And based upon that, we designed a resection margin, sparing the frontal lobe, but resecting temporal, occipital, and parietal tissue. And here's the resection cavity. This is middle fossa, cleaned out. Corpus callosotomy through the posterior 2/3 of the corpus callosum and leaving the posterior thalamus there. Very abnormal tissue, as you can see here. And here's his post-operative MRI. And he did very well in terms of seizure control. And this is him back in clinic 6 months out from surgery.
Hi, Ryan.
And you'll see the improved, he still has a mild hemiparesis, but his function is much better here. You can see him climbing up on the table.
Good job.
Your legs out front.
My partner, Stephanie Eyehouse, interviewing him.
What's your teacher's name? Miss Debbie. Is she nice?
Normal speech.
Kindergarten. Show me your right hand. Give me 5 on your right hand.
So not perfectly normal, but good enough hand preservation.
Miss Penny? On your right hand.
That he still has good dexterity in his hand.
Good job. Okay. Can I have it back?
And
Good job. Okay. Let me see you get down here again. Whoa.
he dropped the penny, so he's going to go for the penny. But you can see his gait.
You wait. Okay. Can you go back and sit on your mama's lap?
So much better than his classic hemiphoretic gait and also the hand that he would have with a hemispherectomy. So in terms of complications, in particularly young infants, we worry about coagulopathy. I'll make the point that I had the misfortune to have a company bring in an infant cell saver for a 3-month-old with Hemimegalyncephaly that I was doing a functional hemispherectomy on. And we were salvaging blood as we went along, cutting the white matter, bipolaring, coagulating, sucking. And after 100 cc's, started to give blood back from this infant cell saver. And instantly, the patient went into a horrible DIC. I think because when we cut through the white matter, we release a lot of thromboplastins that were not filtered out with the cell saver. And I was barely able to save the infant because of horrible DIC. But fortunately, we were able to. But I've never used a cell saver for hemispherectomy since that time. Aseptic meningitis infection. It's easy to confuse a low-grade infection for a chemical meningitis in these patients, and to the point, if they have a stiff neck and photophobia, it's worth doing an LP to make sure it's not an infection. We talked about infarction and swelling. Hydrocephalus, and in my experience, it's not a hydrocephalus that typically causes raised intracranial pressure, but it's more of an NPH type picture where the children may have trouble with bladder control, trouble with gait, and trouble with cognition that may improve with shunting. And then lastly, superficial hemosiderosis, as we've discussed. In terms of failed disconnection syndromes, obviously 25 to 30% of these patients may continue to have seizures. And at least in my institution, whenever they continue to have seizures, the neurologists tell the surgeon that he must have left some tissue behind. And nowadays, DTI and tractography is a very nice way to show disconnection. Here's a case of an overgrowth syndrome with dysplastic hemisphere, as you can see here. I did a disconnection that to me was very good, but when you're doing the disconnection under the microscope, sometimes it's hard to tell on postoperative imaging, and the radiologist raised the question of whether I'd forgotten to disconnect a portion of the corpus callosum here, but you can see with the DTI that there are no crossing fibers here. You can nicely see the fibers that go down to the brainstem and come up for the other side. But being able to prove that the disconnection was complete saved the patient a return to the OR for exploration. Nowadays, not necessarily the future, but in current era, people are doing minimally invasive endoscopic assisted disconnections through small openings in the brain with much less blood loss. Others are reporting doing laser ablation disconnections, as you see here, through multiple trajectories, disconnecting the white matter tracts with a series of tandem laser ablations. And so I think in the future, we'll see more and more of these minimally invasive procedures as a way of minimizing postoperative complications. So I'll stop there, and I appreciate the opportunity to present today, and I'll take any questions unless you'd like to wait till later.
No, Rick, I think we'll go on with questions right away, because I gather that you are doing call and you may have to suddenly disappear. So what I would, it's been a very nice overview and some interesting cases. I would like Sangeeta and Rajesh to ask you questions. I have a couple of technical questions, but I would keep that after their discussion. Rajesh, you have any comments, questions?
Yes. Thank you, Professor Rupert, for a very nice talk on. We have been doing this vertical approach, and that seems to have fairly less complications. With two questions. One is that have you used that for hemimegalyncephaly? Because as you know, it's a little difficult to sometimes disconnect the frontal, mesial frontal region because of their disturbed anatomy.
Yeah, I think the hemimegalyncephaly patients are probably the most difficult hemispherectomies we do. Not only is the anatomy distorted, but there is a fetal pia that can be very vascular. And I will tell you that the worst outcome I've ever had from a hemispherectomy was in a infant with hemimegalyncephaly, where I was trying to disconnect the frontal lobe and got into the hypothalamus because the anatomy was so distorted. The midline was not where it was supposed to be, and that infant did not have a good functional outcome after the surgery. So I think coming down from a superior approach is a good approach to find the midline in these patients. The problem I have with them is typically they're very young because this is an infantile catastrophic epilepsy. The first hemimegalyncephaly patient I did was 4 weeks of age at the time of hemispherectomy, and the only way we could keep him out of status was through general anesthesia until we disconnected the hemisphere. Most of the blood loss in the infants is not on the arterial side, it's on the venous side. And those interhemispheric veins can be very vascular and difficult to control. So if I come from a midline approach, nowadays, I'll try to leave the pia intact and do a subpial resection down through the interhemispheric fissure to try to leave that venous blood supply intact going into the sinus, at least in those young babies.
Yep. One more question. Do you use, for example, parents are always worried about worsening of hemiparesis because some of them have fairly, intact, even not normal hand function, but function is not too bad. And we have been started using DTI to see the asymmetry of the tracks. How do you sort of approach this problem in patients who are mildly hemiparetic and parents are worried that they'll become a complete hemiplegia after surgery?
Yeah, that's a perennial problem, I think. A good friend of mine here in the States had a whole lawsuit with a family who sued him after a hemispherectomy. Even the girl that was seizure free, he had warned them that they would be hemiparetic after surgery, and the family said that they didn't understand that it meant she would lose her hand function. So I think the families have to be warned repeatedly by both the neurologist and the neurosurgeon that their hemiparesis is probably going to be worse immediately after surgery, and that over time, with therapy, they will get back to walking with a circumduction gait. They'll get back to having gross motor use of the arm, but they won't have more than flexion in the hand. I think that the preoperative counseling is what's critical. But typically, these patients have such catastrophic epilepsy, the family is willing to take that trade-off if they can have seizure freedom.
Yeah, thank you.
Morning, Jeff.
Very nice talk, and I think you made our fundas very clear regarding the types of hemispherectomy. I have a couple of two questions. One is, what is you said about this temporoparieto-occipital disconnection? Have you done this with the patients with eulegidia or hypoxic brain damage, which may be, the seizures coming only from one side, though the lesions? So any experience in those patients? Because in India, we see them in a large proportion.
Right. I've done about 3 of those. I've done the one that I showed you that was a resection, and then I've done 2 that were disconnections. Not for hypoxic injury, because that's going to be more global, but in patients who have developmental disorders or trauma that involves temporal parietal occipital lobe but spares frontal lobe.
Yes.
And it's important that the ictal semiology appears to be sparing the frontal lobe. Otherwise, we would consider doing a hemispherectomy. But if they've got good motor function, particularly a good useful hand, then that's a good technique to try to preserve hand function in those patients. I think it's important that if you do a TOPS procedure, that the family understands very clearly that if it doesn't work, then you're going to go back to surgery and convert it to a functional hemispherectomy.
Yeah, I mean, those patients, do they have this visual malfunction beforehand only, or it's that you explain to them that this is the new deficit they're going to get?
Yeah, I've had it both ways.
Both ways, okay. And what's your experience on the reflex epilepsy? Some of these children also have the reflex. I mean, I feel that reflex epilepsies don't, have good prognosis even after doing the surgery. They don't improve so much, even when they have a tactile and a sound which makes them fall. So even when we have done a callosotomies and this thing, the reflex part still remains to some extent, and that really upsets the parents. So I just wanted to know your opinion on your experience on this.
Yeah, I don't know that I've looked at that. I don't think I can give you an answer there.
Okay,
that's
thank you.
Interesting observation.
I would like to ask you a couple of questions, Rick, based on you have shown different techniques and how techniques evolved. Your current practice, which approach to take? Does it depend on how much is the ventricle dilated? I mean, do you prefer one approach for dilated ventricles and another one for a case like hemimegalyncephaly or cortical dysplasia?
Yeah. No, I mean, the hemimegalyncephaly patients all have a dilated dysplastic ventricle on that side, so that makes it easy. I typically will start with a large temporal lobectomy. I like to have a large path specimen, and then we, as I mentioned, will send that tissue to the laboratories of several different people. One of my best collaborations is with a PhD who does blood vessel physiology, and the research that he's done with the blood vessels from these patients has led to several grants and a number of PNAS publications. So I'll start with the temporal lobectomy, frontal topectomy, fairly classic Montreal resection. If it's a more normal patient, then the periosteal hemisphrotomy that Shram described is a very good operation that I like because it's easier to preserve the distal middle cerebral branches through that. That's a good place to have residual seizures if you don't get a good insular resection. And the other is the posterior subfrontal region underneath the anterior cerebrals is a place where I've had to go back because I left tissue there before.
Hey, Rick, may I share a pearl that I learned from Shrum?
Yeah.
Because I was scared of falling into the hypothalamus as you follow the A2 back. And I think most people are, because you're not going to hurt children by going forward onto the planum. And so, like I always say to my fellows, most of us leave that triangle of subfrontal tissue that's disconnected. And Schramm's an amazing guy. I literally can remember the meeting. I think it was the AANS. I'm not sure which meeting it was, but he was standing literally by himself having a dessert. And I grabbed him. I said, Professor Schramm, I have this problem with this. And he says, you must not ever let go of the pericallosal once you have it. Once you have the pericallosal, it is your ticket home. Never let go of it and follow it all the way back to the bifurcation. It will keep you out of the hypothalamus. Follow the A2, pericallosal, the A2, follow the A2 to the A1. Take that from the bifurcation out to the sphenoid wing, and you'll never fall in the hypothalamus, and you'll never leave that block of tissue. That's not my idea. That was just a pearl that he shared. And it's been very, very useful for that periosteal hemispherotomy technique that I think is still that's the one that we always use.
Would that be easier, Jeff, or Rick, if you did the Delalange procedure? You're more likely to remain vertical there. And classically, it was described as a parasagittal, not really an interhemispheric. Isn't that?
I think that's right. I was, in fact, going to ask Rick, because this is a thing I've wrestled with, and I apologize for being late. I think I got my hours and my time, mixed up. But so I apologize for missing more of your talk. But one of the things that I'm wrestling with right now, and I really value Rick's comments on this, is I've become very, very comfortable with the lateral periosteal hemispherotomy, lateral to medial, right? It's beautiful anatomy. It's all laid right out. It's logical. It's step by step. But I've also been taken by how useful some of the vertical parasagittal techniques have been. Many surgeons, many of whom in India, have said, this is a fantastic technique. So I've wrestled with that as far as when do I abandon I don't want to sound flip and call it tried and true, but in a sense, periosteal hemispherotomy at this point in my practice is pretty tried and true, and abandon the tried and true for something new that I'm not as confident I can get as good of a result. So, Rick, you've thought a lot about these things. How do you, as a senior surgeon who's done a lot of epilepsy, tumor, other difficult neurosurgery, how do you let go of the familiar, trying to keep current and embrace the new? What are your thoughts? How do you do that?
Well, the older you get, the harder it is to change, Jeff. I will tell you that. I mean, what some of the younger people are doing with the endoscope and with the laser is just remarkable. I can't remember the fellow's name that spoke in Jaipur a couple of years ago, but he had a huge series of hemispherectomies that he'd done, endoscopic assisted with a very small opening. And
Sharat Chandra. Yeah.
Sharat Chandra has done a fair amount, and I think many of us have learned to do at least endoscope assisted procedure, and that becomes easier with a vertical hemispherotomy.
Rick, I want to ask one question. Periinsular, do you do the temporal lobectomy first or the topectomy first? Because you would lose the sight of if you open the temporal horn, the CSF would drain away. Then going suprasylvian would to catch the ventricle there would be little challenging. So would you do the suprasylvian part first, or the temporal lobectomy first?
I always start with the temporal lobectomy. It's once you take out the temporal lobe, you can disconnect on around the incisura, undercutting the white matter, and then that takes you back to the atrium, and it's very easy to do the topectomy there, and you don't need a very big frontal topectomy, just enough to be able to see into the frontal horn and do the disconnection anteriorly.
Could I ask one question?
Thanks very much, Rick.
One question?
Go ahead, Brajesh.
Sorry, sir. Actually, we've had a couple of patients who had lesions which are, more anterior and more posterior, and motor regions are basically spared. So do you do, because a top obviously would not be enough. So have you done motor sparing hemispherotomies or hemispherectomies?
Only through this TOPS procedure. When you look at the epileptogenicity of different cortices, your hippocampus and your motor strip are going to be the most epileptogenic of the cortices. So for me, having those out or disconnected seems to be logical.
Okay, thanks.
So I think in the interest of time, we'll move on. Is Jeb back in his seat?
I am, yes.
Yeah. So would you please start your talk? I think Dr. Muzumdar already introduced you.
Yes.
Jeff is from Birmingham, Alabama, and he's the chief of the division of neurosurgery there. Main interests, as far as I know, are epilepsy surgery and spinal dysraphism surgery. Is that right, Jeff?
That's exactly right, Chandrasekhar. Thank you very, very much. Well, thank you to everybody for the opportunity to summarize and present this. We're going to talk this morning a little bit about extratemporal resections, which, as everybody knows, is a very, very broad topic that somewhat defies a simple categorization. Some of the genesis of this for me was this lovely meeting that happens every couple of years, often in Europe, about epilepsy surgery techniques. And I put this slide in as much as anything else to draw people's attention to it. Of course, COVID has changed everybody's travel and whatnot. But this is a wonderful meeting, and it was going to be, I think, in 2020, and so it's on hold. But it's worth keeping your ears and eyes peeled for. Arthur Kuckert from Brazil typically organizes it, and it's well worth the time, whether you attend in person or follow up the monograph. Well, the basics of this are that extratemporal resections are common, and that they are challenging in that oftentimes the imaging is either normal or subtle. The cornerstone to successful extratemporal resection, I would submit, comes from a standardized sequential logical process of localization, which is essential and sometimes can be very difficult. Because of a significant percent of normal or near normal imaging, invasive electrodes are often necessary to refine the non-invasive look. As a result, both grids and SEEG have evolved to positions of importance in refining and planning extratemporal resections. The seizure-free rates hover around 50%, and I think that bespeaks the challenge of neocortical epilepsy, even in a modern era. And if we're frank, we're making improvements, but in terms of our overall seizure freedom rate, I'm not so sure that that's where we're getting better. We're getting better as far as being less invasive and probably less morbidity, putting children through less. But I think we're still ending up, some people say all roads lead to Rome, and Rome is 50 to 60%. I still would submit attention to surgical detail is critical to optimize the outcome. Well, just in terms of very sort of summary statements about extratemporal resections, just lumping them all together, it's really too broad of a concept for clinical utility. And when one looks at the literature that's been written on this, each of the epilepsies, whether it be frontal, temporal, parietal, they tend to be quite heterogeneous, where they've lumped together lesional cases, non-lesional cases, and haven't sorted out various pathologies. There's been an inclination to organize this surrounding which lobe is involved, and that's created a bit of a morass, a bit of a fog, if you will. So I would submit that a simple organizational structure provides a very useful framework from which to try and tackle this. And I would submit that virtually all series show that lesional epilepsy does substantially better than non-lesional epilepsy, which of course refers to the structures we can see: tumors, gliosis, cavernomas, versus the non-lesional cases, which tend to be cortical dysplasia, the malformations of cortical development. Lobar organization's been pursued, but it's of somewhat modest contribution. So the key concepts here are, how do we go about localizing the epileptogenic zone? And so first you have to define what you're after. Well, everybody knows that we're after a medically resistant epilepsy, which is defined as resistance to 2 medications under the direction of an experienced neurologist epileptologist with doses and bioavailability optimized. There's been boatloads of new medicine, and the neurologists continue to bury kids in medicine, but pharmacoresistant epilepsy is 2 drugs not sufficiently controlled. So what about these malformations of cortical development? Well, I always tell our residents that these are lesions that weren't even familiar, weren't even recognized, 25 years ago. And I love this picture on the right, because when you first look at it, your eye kind of catches it, and it looks like kind of a pen and ink drawing of a person maybe wearing eyeglasses and looking down at a piece of paper or down at a book. But when you change your frame of reference and let your mind turn a little bit, you can see the word liar, L-I-A-R, spelled out here. And it's a nice visual twist here. And I like it so much because it bespeaks to me what our understanding of malformations of cortical development is all about. They were always there, but we had to change our frame of reference to recognize that within what we saw, there was something that we did not see, and that is the malformations of cortical development. And once that realization was made, then on came a more refined classification system in which we recognized that these were problems with disordered dissociated cortex, sometimes due to proliferation, often due to migration anomalies that have a complexity to them that's very important to what we do. Some of them are very obvious, like this lissencephaly here. Nobody would miss that. But when one is talking about or considering extratemporal epilepsy, fundamentally, the non-lesional cases are neocortical dysplasias, and this is what we have to be aware of. We have to be aware that some of them are MRI visible, and hence lesional, if you will, but many are not, and that's what challenges much of the evaluation of this. This nice one with an infolded sulcus there, thick and gray. I don't think most people would miss that. The classification system is important, but it's complex, and it's beyond what most people necessarily have in their working surgical rubric or surgical armamentarium. In addition, what are the other lesional cases? Of course, destructive lesions, tumors, the hamartomatous tumors that we're also familiar with. But these are important lesional etiologies of extratemporal, supratentorial, extratemporal epilepsy. That's one component of the of extratemporal resections. Now, to talk to an audience from India about infections, you know way more about this than I do, but many infectious issues leave a big trail of gliosis, scar that's highly epileptogenic, oftentimes generating lesional epilepsy that's very amenable to resection. Well, fundamentally, the challenge of extratemporal resection is localization. And localization is challenging because of the robust projection of neocortex, whether it is contralateral or ipsilateral. There are very robust association and projection pathways that ensure that electrical activity in one region is very quickly manifest in another region, which challenges the capacity of surface EEG to capture it. And the more normal the MRI, the more extensive, as a general rule of thumb, the functional imaging tests and invasive electrodes are to carry forth with successful extratemporal resection. So we all fall back on some variations on a theme, right? A standardized clinical assessment of how do we localize this epilepsy. This is classic sort of neocortical supratentorial neocortical based epilepsy. And so we get clues and we build a story. Same things I say to the residents. You build a story. It's the same presentation regardless of what the epilepsy is coming from. We start with a description of the semiology and the evolution over time of the epilepsy syndrome. We combine that with surface scalp video EEG. Has to be in an EMU, has to be over time. Then we take a picture, MRI. How does the scalp EEG correlate with visible abnormalities? And herein we get the frequent trip up of neocortical supratentorial disease, which is to say, oftentimes the MRI is normal, oftentimes the scalp EEG doesn't particularly contribute, and here we're in the thick of it. And that's, the more we find ourselves at that point after step 3, the more we need expensive and not necessarily widely available functional imaging, either ictospect, ISAS, SysCom, PET, or MEG, to non-invasively give us a flavor whether or not we have sufficient focality to go on with focal investigation. And then, of course, intracranial electrode placement, either by conventional grid and depth electrodes or SEEG. These slides were put in because I wasn't sure exactly who the audience was. Last time I talked at the Indian Pediatric Neurosurgical Society, there were a number of learners in the crowd. This looks like a more mature, accomplished crowd, so forgive the elementary nature of these slides. So everybody has a video monitoring unit. The characteristics, of course, are long-term quality EEG. There's benefit to more than one camera. MRI is the cornerstone of treatment so that we can discern the abnormalities and correlate the surface EEG with what we're seeing structurally. The fundamental correlation between structural information, as evident by 1.5 or 3 Tesla MRI, with functional, which we see as a first look with scalp EEG and as a more refined look with functional imaging studies, is the fundamental cornerstone by which we build a conceptual basis and a rational underpinning for good surgery. And then the functional imaging test. And most centers have 1 or 2 preferred imaging modalities which they've invested in. All of these share common characteristics, which is that they're expensive, they're important to have expertise in, and they require significant refinement. Virtually none of them are effective off the shelf or out of the box. So oftentimes a center will have expertise and refinement in one of these techniques over the other, whether it be PET, whether it be MEG or ictospect. And then, of course, for refinement, we have to think about how do we, in the setting of normal imaging and focality on the functional imaging test, then if we're going to remove brain, we have to move forward to invasive monitoring. And of course, that involves traditionally the placement of subdural grid and depth electrode arrays, often directed by image guidance in the operating room so that we can superimpose some of the functional imaging studies onto the image guidance platforms, and in the operating room place both grid, strip, and then depth electrodes into and around the areas that are important. This modality is increasingly common, increasingly easy, because these are all DICOM-based systems. So the capable people in your imaging centers can super load these, and you can place your electrodes directly over and in. In SEEG, it's exactly the same thing. It's just it comes at a different stage. With grids, it's done in the operating room, wed to the image guidance system, and of course with SEEG, it's done on the planning software program where you superimpose your functional imaging tests, be they MEG, ictospect, or whatever, on your anatomy that you're doing your depth trajectory planning. And of course, senior group like this, everybody's familiar with this appearance of these are hand placed, not robot placed, but in the setting of an open craniotomy, these are depth electrodes placed to localize our epilepsy. This is a nice example of how these functional imaging modalities can be superimposed one on another. The picture on the top left, of course, showing how we placed a depth electrode in the context of a grid array by hand, but because in the operating room we had the MEG superimposed, we were able to directly probe the edge of that MEG hotspot by placing a depth electrode. And again, on the context, extratemporal resections, fairly normal imaging. How do we localize the region of interest? On the lower right, again, right off with the stealth navigation here, we've superimposed regions of hyperexcitability on our ictal SPECT ISAS study with DTI with our SEEG construct, so that we can tell kind of exactly where our implicated regions are, both non-invasively with our ictal SPECT and then our superimposed depth electrode array that was done at a previous investigation via SEEG. So a variety of different techniques available for the surgeon, but each of these requires, an investment of course, resources and time to develop comfort and familiarity with the platform. This is a nice case that we had. It was a challenging case of a physician's son who had bad epilepsy that was emanating from the cortex right where his speech cortex ought to be. His speech cortex had moved. We were able to combine these techniques. He had MRI normal, very debilitating epilepsy. We were able to combine these techniques, and using SEEG and the combination of functional imaging, we're basically able to do a very focal corticectomy directly over the projection pathway for his now moved speech area. And knock on wood, he's been seizure-free for 3 years, where he was getting eaten alive by his seizures before. So what about the collective experience? So fundamentally, I think this is a matter of how we localize things, but there has been a collective experience in terms of the various lobes. And this is the way that this has traditionally been looked at over time. Well, the frontal lobe is, of course, the biggest of the extratemporal supratentorial spaces. And the frontal lobe predominates in virtually all epilepsy series. The evolution of thought and understanding of the frontal lobe is fascinating, right? It started with destructive phenomena, destructive observational cases. And of course, everyone's familiar with this famous case of Phineas Gage that started giving insight into frontal lobe function, right? He was working on the rail. There was an explosion. He impaled himself and had a very severe frontal injury. It was said that Gage was no longer Gage, but the part of the story that gets missed and is of interest to us as epilepsy surgeons is that fits, as they say, he became fitful. Everybody's familiar with Gage was no longer Gage, but what many people aren't familiar with was the extent to which fits or seizures were a part of this story. And that bespeaks a lot of the epileptogenicity of the frontal lobe inherently. Well, then the story goes on a bit, and it became evident that the frontal lobe was both epileptogenic, but that it also had that it could give rise to seizures. Another patient, somewhat later than Gage, had a bifrontal injury, underwent some treatment of cleaning that up, basically, and he was improved from his seizures, and everybody thought he's much better. And it wasn't until the development of the Wisconsin neuropsych battery that they assessed this man and found him to be profoundly impaired, giving some insight that the frontal lobe normal functions aren't, or maybe a little bit more subtle, but that they're still very, very important. This reached popular widespread utility in the early 60s when frontal leucotomy was widely used for the so-called neurologic or nervous diseases, somewhat catastrophically, where large numbers of patients underwent a bifrontal procedure for which there was initial enthusiasm because some of these violent and patients that had other psychiatric illnesses were found to no longer do so, but then follow-up evaluation showed that they were quite catatonic. Well, from an epilepsy perspective, of course, the frontal lobe's the largest of the extratemporal regions, and as a result, it's disproportionately implicated in epilepsy. 20 to 30% of all the partial epilepsies arise from the frontal lobe, and when talking about extratemporal disease, frontal lobe predominates. But there's a lot of diversity, and this takes us back to the original point that I sort of would hang any discussion of extratemporal resections on. And that really is that the robust projections make localization challenging, and that there's a correlation between the degree of imaging abnormality and the requirement for functional studies and invasive electrodes. If the imaging is normal, then you're going to need a lot more comprehensive evaluation with functional imaging and likely the placement of electrodes, be they depth, grid, strip, whatever. These are very varied lesions. They have very robust projections, and the semiology can be frequent, fast, and somewhat challenging. Efforts have been made to try and characterize frontal lobe epilepsy, frontal lobe resections, but to a large degree, the frontal lobe has escaped a practically useful, widely used characterization, despite good groups like the International League, 7 anatomically, clinically distinct regions, but that nobody really falls back on that. It's probably, maybe there's a person here or there that uses it, but for the most part, there's a few phenomena about frontal lobe seizures, semiologies, and things like that that are characteristic that are important, right? There's basically 3 patterns that we see. One is that of a focal motor, the characteristic version of the head with tonic posturing and some speech arrest. The characteristic supplementary pattern, which is very commonly clustering pattern of seizures at night. Tonic posturing may be a part of it. And then the very important partial complex. And this is an important one to realize, because traditionally partial complex seizures have always been attributed to temporal disease. And then as we've learned more, it's become increasingly evident that a frontal lobe epileptogenic region can give rise to a partial complex seizure that imitates the temporal lobe seizure with staring, absence-like events, sometimes repetitive stereotypic movements. And this has given rise to the temporal plus idea that patients who have neocortical epilepsy that look like they have temporal localization very often have a concomitant frontal lobe focus that leads to failures when particularly temporal lobe neocortical resections are undertaken with inadequate study of the frontal lobe. So that's an important one to watch for. And as we've studied the insula more with SEEG, we've come to realize that this frontal insular temporal network is both common and is a common source. They can imitate one another. It's a common source for failures. So what else about frontal lobe seizures? Well, the psychoemotive component is common. Sometimes there's an autonomic component. And when you compare these seizures with temporal lobe seizures, in general, the frontal lobe ones have a bit more of a motor flavor to them. They tend to be brief, and they tend to occur out of sleep. Those are clinical signatures that you can look to discern whether or not you're trying to find a temporal or a frontal lobe etiology for your onset. Well, what about surgical results? Well, there are a whole series of individual retrospective centers from a variety of different places, and they all suffer from a similar thing. Predominantly, they combine lesional with non-lesional cases, and they have a varied duration of follow-up, and the techniques sometimes evolve for assessment over the period of time. But what kind of comes together is that a effectiveness somewhere around 50 to 60% tends to be the most common regions. This is one that the most common areas of outcome. This is one from recently published in World Neurosurgery, a fairly large frontal lobe series. This is an adult and pediatric series. Nicely shown here, utilizing Kaplan-Meier dynamics with, again, about a 50% rate frontal lobe seizures at an average, at a minimum follow-up of 3 years in this particular series. Overall, just over 50% are seizure-free, but 17% with initial seizure freedom in this series went on to relapse. So there have been a variety of different outcome studies in frontal lobe epilepsy, and many of them come together with this sort of common finding of about 50 to 60% seizure freedom. This is a nice meta-analysis performed by Dario Inglet and Eddie Chang. When Dario was still at UCSF, he's moved on to Vanderbilt now. Again, about a 45-degree seizure freedom rate. Lesional epilepsy and an abnormal MRI. Again, this keeps recurring regardless of whether we're talking frontal or parietal. Parietal epilepsy is the second largest, but it only represents a small percentage of epilepsy case series, and it's probably underappreciated because its semiology is less discrete. It still has very robust cortical projections, and much of it is somatosensory. As a result, they're a much smaller series. Clinically, but again, this sort of 50 to 60% series. This is one of the larger series that was published, a combined series by the group in California and Professor Schramm, who we've alluded to before. A couple of more series, again, the same idea here in the parietal lobe. Meta-analysis showing, this larger study showing 253 patients evaluated, localizing EEG, presence of a lesion. Same idea is present in all of these neocortical. When the lesional and non-lesional cases are combined, there's the recurring finding that obviously a lesion is associated, as is a younger age, and localizing EEG in series after series. And those cases are disproportionately represented in good outcomes, with 70 to 80%, and the dysplasia cases below 50%. Occipital, similar concept. Less common, wide range of etiologies. The semiology is often visual, but again, because of robust projections, it can have a variety of different manifestations. It's severely debilitating and it's understudied. There's yet to be any kind of randomized trial. Most of the studies suffer from the same methodologic limitations as the other neocortical studies. No standardized metrics, no standardized follow-up, no standardized duration, heterogeneous etiologies, and evolving both surgical techniques and localization techniques over the time interval of the study. And as a result, they all tend to show a very similar type of thing. This, again, the same group from California and Bonn, generally good outcomes, 35 to 50% seizure, visual field problems with 50 to 60% seizure freedom is what most of the series showed. Dario, again, did another meta-analysis related to occipital epilepsy, combining 27 manuscripts. They got 500 and almost 600 patients. It's a mixed adult pediatric series, of course, because it's a meta-analysis of multiple constituent series. Overall, about 65% seizure freedom, but about 57%, more than half, have some degree of visual impairment. Overall, predictors, children do better than adults, and of course, once again, lesional cases do better than non-lesional cases, taking us back to the same concept that that supratentorial epilepsy is either lesional or dysplastic, and the lesional cases in every series do better. Probably the most important supratentorial neocortical epilepsy for which there's a markedly growing awareness is the concept of insular epilepsy, right? SEEG has really opened the door to this. It's sort of, if you build it, they will come. If you look, you will find. And in a survey that we did of the pediatric SEEGers of about 20 centers, most people, virtually everybody now, about 70% of people that are placing SEEG electrodes are routinely sampling the insula, and as we do so, we're finding that it's important in more and more epilepsies. So this, I think, is the emerging area of great clinical importance with regard to supratentorial neocortical epilepsy. Okay, so what about failures in extratemporal resection? And it's usually due to an incomplete resection of the epileptogenic zone. Early on, and afterwards, it's usually due to a reorganization. Of about 30 to 40% patients that don't originally achieve seizure freedom, about 20% undergo a redo procedure. Relatively few studies at this point have talked about surgical failure and reoperation. One paper out at 213 that underwent, of 23 children that underwent resection with relocalization, found that the reason for failure was kind of evenly divided. It was either incorrect localization, various functional considerations, or some form of technical failure. But more importantly, almost 2/3 who undergo reoperation show significant improvement in seizure control. 60% of these kids were seizure-free after a reevaluation and a re-resection. So I think that, that there's a role for being perseverant here. There's a role for patience. There's a role for setting this up with regard to the way one obtains informed consent. So how can we do better? With regard to extratemporal resections, I think localization remains the key, right? Conceptually, we can talk about lesional epilepsy, we can talk about non-lesional epilepsy. Localization in non-lesional cases remains the challenge. And the holy grail here, of course, is source localization, right? Better functional imaging in terms of mathematical manipulation of some of the source data, high resolution electrical source localization, increased signal to noise ratios. These are the sort of holy grail mechanisms by which the functional imaging modalities continue to improve. In addition, I think we're going to see growth in terms of the intracranial investigation. I was interested the other day when I heard Dr. Spencer from Yale talk about how they're preferring now, when they place SEEG, they will place SEEG very often around a craniotomy and use SEEG to investigate depth regions of interest, and at the same time turn a small craniotomy and place some strips and grids right over the top. So he's abandoning the kind of either or phenomenon that so many of the rest of us are evolving to. Extensive intracranial investigation and better source localization, I think, are the directions that may take us to better understanding and better outcomes for our kids. Of course, we're getting better technologically as well. Grids and depths and SEEG continues to become more refined. The localization is getting better. Each iteration of the software is easier to use and it's more precise. Okay, so summarizing. Neocortical extratemporal resections basically is neocortical epilepsy. And the substrates, they're either lesional or they're non-lesional. And the non-lesional cases are cortical dysplasia. And cortical dysplasia requires functional imaging studies, and it requires intracranial electrodes to do it in a rational, quality way. There's an inherent significant challenge related to localization because of the robust projections of neocortex. A standardized process allows a rational localization and provides an intellectual underpinning to surgical resection of extratemporal neocortical epileptogenic regions. We're probably going to need more depths. We're probably going to need better source localization. We're probably going to need improved fusion to guide better placement and refine our capacity to localize and identify these regions of neocortical hyperactivity. Right now, we're still in about the 50 to 60% region, but I think that this will continue to improve. I thank you all very much for the opportunity to present here, and I've really enjoyed my interactions with the Indian neurosurgeons that I've come to know and learn from over the past 2 to 5 years, and I welcome any questions, comments, or critiques. Thank you very much.
Thank you.
Thanks, Jeff. I think that was a very good overview with some illustrations, and I think Sangeeta has had to leave for some other meeting. There are several workshops happening today.
Sure.
So you will have to excuse some people missing, but Brajesh, I'm sure, is ready with questions.
Yeah, very nice.
Are you there,
talk.
Brajesh?
Thank you, Professor Blount. I had a question on the SEEGs, a couple of things. What percentage of your pediatric patients and how young do you do SEEGs? Because one of the problems I always face is when I'm trying to evaluate a patient who's, say, non-lesional or trying to sort of formulate a hypothesis. And very often before we decide to place, very often the semiology is a bit different, is not as localizing as adults. You don't get the auras, which can tell you where the ictal onset may be, and therefore it's always difficult. And of course, number two is how young do you do that? What percentage is SEEGs and what percentage is subdurals?
Yeah, this is a great question, and this really gets to the core question that so many people are asking right now, is really what is the role for SEEG? And in a perfect world, it would all be perfectly cooperative and perfectly rational, and we would all be, making decisions off of good data. In a practical world, it seems subject to all the whims of human behavior, right? I work for 4 different epileptologists who have pronounced differences in their biases and their stereotypes. One of my epileptologists has all but abandoned grids. Another of my epileptologists still feels that grids are preferable and that SEEG is going to be a dangerous flash in the pan, a very role and whatnot. So I think at this point, there is variability. There's a fair variability that reflects practice preference at different centers. I worked with Ben Kennedy at CHOP, and we did a survey of the pediatric centers in North America about the use of SEEG. There unequivocally is an evolution toward SEEG, and it's about 70% of pediatric investigations in North America seem to be utilizing SEEG as a predominant thing. And the rationale there is that it's a little bit, it allows a better look, a deeper look. It allows less discomfort for the patient, right? Because the individual nicks and anchor bolts are less uncomfortable than a grid just with the wires hanging out. And like we alluded before, the notion of the insular involvement is a big decision maker as well. So I think my answer to your question is there's a lot of variability from center to center. There's a strong evolution toward SEEG in North America in children. And I think about between 2/3 and 3/4 of centers now are using SEEG preferentially. That doesn't necessarily make it right, but that's what's, I think, happening. And then with regard to age, there's a kind of, they talk about a glass ceiling. Well, maybe there's a glass floor that people talk about. Under age 3, the bone thickness gets very, very thin. Now, Dan Curry in Houston says you don't need anchor bolts. You can put the thing in with an anchor bolt and then take the anchor bolt out. But in my experience, I've put them in as young as like almost 3 years old. My youngest kid is 2. But I tell you, it is a different enterprise because you have to be extraordinarily careful in placing those anchor bolts that you don't plunge. The anchor bolt never gets the same purchase, so you can get torque. You can get torque not only in putting it in and thereby a slightly different trajectory, but also while it's in or removed. The Colorado group just published a case report of a catastrophic intraparenchymal hemorrhage associated with flexibility of an anchor bolt. I mean, it's a hemorrhage you look at and you go, oh my gosh, did the poor patient survive? They report that they did, but it's a quarter of the whole hemisphere, right? So there definitely are issues, and I don't think we should be complacent or relaxed about this. I think we should continue to press for good quality bolts and things like that are specific for young children that have 2 and 3 millimeter temporal squamosal bone, so that we can use this and make anchor bolts safe. You will hear people say, "Oh, you don't need them," and that's true until it's not. There have been some disasters. So about age 3, about 70% in North America. There's definitely an evolution toward SEEG, but there's, I think, amongst thoughtful people, there's still a little bit of recognition that being able to map the surface with a grid and maybe a role for combined treatments, I think that's still going to, the pendulum may swing back a little bit.
No, I agree with you. We also, everybody in India also, whoever's doing invasive monitoring are basically using SEEGs and the subdural grids. The only problem I face is sometimes when you're operating near the motor regions and you do not have any weakness or anything of that sort, then the question is, as you know that it's very difficult to functionally map areas using SEEGs because they're so narrow and thin, and they do not
absolutely. And,
so
the depth of reach of an SEEG electrode is only 1.2 millimeters on each side, right?
Good.
So I say to my residents, and it may be a silly analogy, but it enables them to get it. I said, okay, think of the seizures as fish in the bay. We're going to go out fishing, okay? And we have 2 choices. We can either bring nets and throw nets on the surface and get a pretty wide capture, but we're stuck with what's kind of on the surface, and we may be able to pull our nets down 10 feet, or we can bring spears, and we can throw spears into the water. Now, the spears, they have their advantages. They allow us to look deep. They allow us to reach deep. but we better have our accuracy pretty darn good because we can't reach very far with our spears. Our nets give us a bigger reach. It's very superficial, but they let us look at a wide range of cortex. For cases where we're near the motor strip and certainly where we're near speech, we will often supplement, do an initial SEEG, and then put a grid in to map it out. Because most of my epileptologists don't trust the SEEG sufficiently to tell you surface rendering for speech.
Yeah, so for example, what we use is awake surgeries in older patients.
Nice,
but,
yes.
Below 10 years of age, it becomes a little difficult to
You
do
bet.
awake surgeries. Yeah, that's why.
You got to have a very mature 10-year-old to even be able to do that. And in our experience, the biggest challenge with the awake cases, and you probably have way more experience than I, but is not the incisional pain, but it's lying still on a hard table for a long time appears to be way more uncomfortable for the patient than a properly done local block. Is that your experience as well?
Well, I'm not a neurosurgeon, but Shekhar can answer that.
I think especially in children, it is difficult. I mean, they need to be kept engaged. It's extremely difficult otherwise to keep them still.
I agree. Right?
We have done a 9-year-old, but otherwise, yes.
I
Below
remember
10,
that patient, yes.
Yeah.
I have one question, Jeff.
Yes, sir.
Considering all this SEEG, as you correctly mentioned, I have two questions. One is they are now using functional connectivity MRI, the FC MRI. It's still nascent, but I think that would maybe if it clicks, that will take away a lot of other things. And the next thing is the spike onset zone, which now John Gottman from Montreal is propagating. So the perilimbic network and the insula. So we are not getting to the spike onset zone. We are concentrating on the epileptogenic zone or the irritative zone, which is vast. So now to tailor it to the spike onset zone, using non-invasive techniques would be the ultimate thing.
Holy grail. I absolutely agree. My case last week, we put 10 electrodes in on each side, 11 on one side, 21 electrodes in this girl, okay? With very, and on the implicated side, we were right near it, but not right on it, right? So we took her back. We took everything out on the non-implicated side, except for the mirror image of what we thought was important. And we put 4 more in just to try and find exactly what you're talking about, right? Because that's the hard part with SEEG.
Yes.
My epileptologist, Ismail Mohammed, could stimulate and get a semiologic event that was identical to her seizures, but he wouldn't get an EEG signature. So we knew we were right next to it, but we didn't have the region of epileptogenesis. So we found ourselves in the difficult situation of, do we expose this kid to another risk of implantation, singularly to refine the look, or is there, and you can imagine all kinds of ways that this will get better in terms of the processing, but we're just not there yet. So, back to my analogy for the residents, we go and we throw our spears and we get some fish, but I think 10 years from now, the engineers and the technical neurologists who manipulate and I don't want to say play with, but sort of play with these data, I think are going to be the people that really move this forward.
Yeah.
I also think it's going to be interesting in the future, the trajectory planning. I don't know if any of you have participated in trajectory planning with the surgeons, but I find myself sometimes thinking this is a bit of a fool's errand. When, if you think about a least squares calculation in statistics, the computer can calculate a least squares like that, right?
Yeah.
And what's it doing is it's calculating various distance from the line for a data point, and it's calculating the line that has the best fit, right? Well, what the heck else is a trajectory, right? A trajectory is exactly the same thing. It's just the data points are hyperdensities that reflect contrast in a vessel.
Right.
Or by contrast, give it a different number or a different signal to the machine, a zone you want to hit, right? A zone you want to hit, a target zone versus a zone you want to avoid. That's exactly what computers do really, really well. So it strikes me that smart engineers and software planners should be able to give us trajectories, and then our role would be to come and pick, well, we'll take these 6 or 7 trajectories instead of these other ones because of temporal bone and tangential and, these other surgical considerations. I think that will come. I'm not experienced, skilled, smart enough, whatever to do.
As a surgeon and with precise location, and the functional areas, how much today you think is the importance of imaging in terms of the anatomical landmarks as against the physiological data which you use for either mapping or for target? What do you think is the proportion right now in your
I think that the anatomic landmarks are still critically important when you actually do the surgery and do the resection. I say that to the residents every time. Do not rely on your stealth. Your stealth is the backup. It's just like the navigation system in your car. Have thought through where you're going. Don't just drive on the purple line. And the same with the stealth. Now, with regard to the actual planning of the trajectories, that's a physiologic phenomenon, and it's often deep. So I kind of plunge into, I take the plunge of faith into the technologic showing me where the hot spots are with regard to planning trajectories for SEEG and things like that. But with regard to doing the resection, opening it up, looking, I think it's absolutely critical. So I guess I'm dodging your question a little bit because it's not an either or. It's when you place the trajectories, it's all the functional imaging technical stuff. When you do the surgery, it's 2/3, 3/4 your recognition of the anatomy, and then perfectly fine to back it up with stealth and things. I love it when we can have stealth registered because the stealth will now co-register where the SEEG electrodes are. And I can literally bring the epileptologist in the room. I say, see this hole? Look, see the hole? Look with your eyes. See this hole? Now look, this is where electrode 2, 3, 4, 5, and 6 were, and those are the ones you told me are hot. And that is very settling to them that we've done an appropriate and adequate resection.
Great, Jim. I think
it's been a great conversation. I really enjoyed talking with you all about this.
Thank you.
I can tell you're very interested in and really challenged by these hard problems.
Thank you.
If you have some time, please stay back. Datta is going to talk to us about his experience with temporal resections in children before we end the day.
Yeah, I told my residents I can't be there for another about hour and 15 minutes, so I've got some time.
We'll enjoy your comments on that as well. So that brings Dr. Datta Mazumdar, convener of today's program and professor of neurosurgery at the KEM hospital and taking special interest in epilepsy surgery. Over to you, Datta.
Thank you very much. Thank you, Dr. Dev Pujari. And I thank the panelists as well as the esteemed international speakers. I think we have learned a lot, and that this is just the start of learning. So now I would come to the most common topic, which is the temporal resection in children, and most of them are drug refractory. So I would just going to give an overview of what does it mean and what is our experience. So everybody talks about early surgery, and there is no question that early surgery is required because it gives you seizure freedom, it gives you withdrawal from the anti-epileptic drugs. Sometimes there are evidences of SUDEP which can be avoided. Then if you wait for too long, there could be kindling phenomenon, and all these things would if they're tackled, then it would lead to a possible enhanced quality of life. And mind you, once this quality of life is enhanced, there is another problem of burden of normalcy of all these children who are normal to undergo epilepsy kind of rehabilitation, because all the time they are compromised because of the comorbidity. So those need to be also looked into. The figure on the right, just to illustrate that there is a neocortical and a mesial temporal lobe epilepsy, and what connects is to it is the perilimbic network, which involves the basal frontal as well as the insula and the limbic system. So here I would go a reverse way. There are many series in adults, and it is unquestionably proven that surgery is beneficial for temporal lobe in adults. Correspondingly in children also, there are quite a few of series mentioned in the literature. And these are the few case series which I've mentioned. There is only a randomized study reported in New England Journal by the AIMS group, as well as Dr. Radhakrishnan from Sri Chitra has reported about preventing epilepsy surgery in lower middle class income group, which is very pertaining to the Indian subcontinent. And I would a little bit stress on that, how our surgical paradigms change apart from what the global recommendations are. So the Miami group and the Bonn group, the recent publication also summarize a lot of things about pediatric temporal lobe epilepsy surgery. And obviously, everybody is a proponent of early surgery. So, what are the outcome determinants? So, seizure freedom is one, and most of the series they talk about 1 year, 2 year seizure freedom, but not many people talk about 5 year and 10 years, and that's what is most important, because we know early surgery is important, and there is a good seizure freedom rate at 1 year or 2 years. So it is found that a good seizure outcome would be evaluated at 5 and 10 years. So at 5 years, it is about 70 to 86%. And if you see, it declines to about 40 to 60% on follow up more than 10 years. And these are the three publications that I would refer to, where they have significantly mentioned that long term seizure outcome at 10 years, there is a significant decline. So these patients need to be followed up long term and not at 1 or 2 years or 5 years. So other also in quality of life, when you mention quality of life, it is not only the seizure freedom, but the seizure outcome. Now, outcome includes comorbidities of epilepsy as well. And I have just summarized this. So seizure outcome would entail, apart from seizure freedom, which is very good, about 70 to 80% at 1 or 2 years, the neuropsychological outcome, which includes language, memory, speech. And if you see in the literature, you may not see immediate improvement, but in the time to improvement, it is prolonged. So more than 6 years sometimes. Sometimes you get ipsilateral benefit is essential, but only even contralateral benefit also we do get. And if there are preoperative lower scores, they fare better. So there is a chance of improvement. Maybe the scores are less or low because of many other factors of the comorbidities or polypharmacy or many other situations. Then is the cognitive and the intellectual development. The earlier the onset of epilepsy, the better is the outcome for seizure freedom, but it may not be better for the cognitive and intellectual development because of the insult that these children have in the intrauterine life or during development. Obviously, polypharmacy adds to that. Left-sided, if there are intact scores, that also has a bearing on the cognitive and intellectual development following surgery. And we again don't see any significant improvement in the first 2 or 4 years, but long-term results need to be awaited for conclusively tell about all this, the cognitive and intellectual development. Obviously, psychopathy, emotion, behavior, and psychosocial aspects. Most of them, 2/3 of these patients have got the psychopathy before surgery. And sometimes these patients develop de novo psychiatric illnesses after surgery. So 20% of them would develop. And overall, if you see, because of the entire paradigm of epilepsy and its effect, 50% of the patients will benefit after surgery because of the comorbidities, and they will show a good remission. Although they require to be seen by the multidisciplinary team till lifelong, or as long as they go into the adulthood as well. So there are beneficial effects of surgery on the comorbidities, but it may not be 100%. We still have to evaluate them on a long-term basis. There are challenges. The duration of epilepsy. The shorter the duration of epilepsy, the better is the outcome. Now we have, when in children, as you know, it is not more of hippocampal sclerosis as we see in adults, but more of tumors, lesional epilepsy, and the focal cortical dysplasias. Sometimes we have to intervene early because of the neuro-oncologic implications, because we need to have the tissue diagnosis, we need to understand the characteristics of the tumor, and sometimes subject them to adjuvant treatment or further observation. So there is always a conflict whether we need to intervene early as far as neuro-oncologic considerations, or we need to intervene early for epilepsy surgery. So for polypharmacy also has a challenge. Sometimes there are complex seizure semiology in young children which may not have a seizure pattern, which requires more studies. And neuroimaging, mind you, unless you are in a multidisciplinary team, in spite of being in this incomplete myelination or secondary hippocampal sclerosis, or sometimes the incorrect radiological interpretation, that would be a non-specific pathology that could be a challenge. And obviously focal lesions in genetic epilepsy. So we see a lot of autoimmune or genetic epilepsies, and sometimes they're present with focal lesions. Although catastrophic epilepsies or increasing seizures in a genetic situation, patient may still be advised surgery, but that may not give as good as outcome as a non-genetic cause. The temporal lobe epileptology in children mainly are, as I mentioned, focal cortical dysplasias. Mainly one, type 2B is the balloon cell, and type 3, which is always associated with the hippocampal sclerosis, associated with either trauma, gliosis, or a cavernous malformation. Tumors usually are low grade. They could be strictly neocortical tumors or with or without mesial temporal structure involvement. Hippocampal sclerosis, there could be hippocampal dysplasia, microdysplasias in the hippocampus, or there could be an abnormal hippocampus, which is a mal-rotated or vertically placed hippocampus. Although that is not a predictor for outcome, but still you have an abnormal hippocampus. Or there could be a temporal neocortical lesion with affection of the hippocampus, or there could be an extratemporal lesion, as Jeff just mentioned, that we could have a secondary, could have a frontal lobe epilepsy, or we could have a oligodendroglial hyperplasia, which is quite a known entity now, the Moge entity with dysplasia. So the cause is in the frontal lobe, and we are evaluating the temporal lobe. So we have a close look on the extratemporal or the seizure pattern and the limbic circuit. More non-lesional, sometimes both the hippocampi are normal, or it could be a normal hippocampus. It is very difficult. Again, it comes in the temporal plus kind of a situation where the focus may be mainly in the insular opercular area, or the orbitofrontal or the temporofrontal occipital region. This is a classical slide which has been there for a long time. So here we have all these remediable lesional epilepsy syndrome, which I just mentioned, which could include all the low-grade pathologies for the low-grade tumors and the dysplasias and the vascular malformations, gliosis, scars, and sometimes localized form of Rasmussen's encephalitis. So epilepsy surgery in temporal lobe, we have grouped largely where you require only neocortical lesionectomy. Sometimes we require neocortical lesionectomy with a mesial temporal resection, which could be either a selective or it could be a standard ATL. And there is an entity known as multiple hippocampal transactions, which is also been propounded in certain situations where the lesion is close to the hippocampus, and we have a hypothesis where the hippocampus is affected, although not involved, in addition to the lesion. This, as Jeff pointed out repeatedly, that this cannot be circumvented. You have to have a good clinical history, a good exam, seizure semiologist. Most of the epilepsy surgeons have to know epileptology and the EEGs if they have to do epilepsy surgery. So there has to be a basic understanding apart of the seizure pattern, the seizure semiology, and obviously the standard workup needs to be done about the intrarectal EEG, video EEG, PET, SPECT, pretest lab, MRI, and obviously neuropsychology, psychiatry has to be the part of the group, part of the multidisciplinary team, and not to forget the visual exam, because sometimes our post-surgical visual deficits can be an issue either on the exam or the patient might complain. So this visual perimetry exam has to be done. Non-invasive recording, I just mentioned that we largely in our subcontinent would rely on non-invasive recording to the core. This is just now I mentioned about the functional connectivity MRI, where probably the bold signals could give us more information of the connectivity in the future, and the resting state functional connectivity patterns would help us to understand the hypothesis of the circuit better. Now, insular hypometabolism. So if we say insular hypometabolism, it is a negative predictor for surgical outcome. So if it forms an important part of the evaluation of temporal lobe plus epilepsy, and if there is no hypometabolism in the insula, then your surgical results may be a little bit better after the surgery around the insula or the where the insula is affected. So where will we consider invasive recordings in our situation here? So if there is an anatomical proximity of the lesion with the mesial temporal obstructures, if there is a dominant side lesion with normal hippocampus, sometimes the neuropsychologist checks intact verbal memory scores and we have to operate on the left side, and evaluation of seizure spread with relatively preserved memory and language. Neocortical lesionectomy, this is what I have realized over a period of years, that if I see a normal white matter around anatomically, if I see a normal white matter around the temporal horn, now the distance from the mesial temporal structure should be a distance of more than 1 gyri. So that would give me a fair idea that, okay, this patient might, apart from all the other seizures, taking into account all the other profiles, surgically, if I see that it is more than 1 gyri, maybe I can get away with neocortical lesionectomy. Intraoperative ECG showing no epileptogenic activity on the hippocampus. So if I suspect, I would open the temporal horn and do a recording on the hippocampus, and obviously in left-sided lesion with intact verbal memory profile. So in those cases, we would resort to neocortical lesionectomy. So here I would show some examples. So now there's a right amygdalar lesion, and these are the cases where I would do only neocortical lesionectomy. Neocortical amygdalar lesion, low-grade glioma, it is close proximity to the hippocampus, but hippocampus is normal. Patient has got ADHD, moderate MR, but intra-op ECG was normal. So here, in spite of the seizure semiology and everything to take an account, if my hippocampus is normal and intra-op ECG is normal, I would resort to only amygdalar lesionectomy. And here, if you see, I've done that, I've spared the hippocampus, and on the hippocampal, we did the ECG on the hippocampus bed as well as the resection bed. Hippocampus doesn't show any activity. And after the resection, the neocortical epileptogenic spikes have disappeared. Left-sided amygdalo-uncal low-grade glioma. Again, hippocampus is normal. There is mild memory impairment. So left-sided mild memory impairment. Intra-op ECG on hippocampus was normal. So in this case, even if there is a mild memory impairment, since the hippocampus was structurally normal and intra-op ECG was normal, we would give the benefit to the patient and do only lesionectomy. Fusiform gyrus cyst, again, memory is normal, left-sided, no intra-op ECG spikes, no to do only lesionectomy. So low-grade glioma with focal cortical dysplasia. If you can see that the low-grade there is a peripheral lesion here. Normal hippocampus, normal memory, no spikes on intra-op ECG, only lesionectomy. Low-grade glioma with FCD. Now here is a low-grade glioma. Normally we use, if we sometimes do not have stealth or do not have navigation, I use the marker MRI, which I found it very useful. So just the day before surgery, I put the marker MRI. I don't need to use any intraoperative navigation and straight away perform a very tailored craniotomy and do the resection. Here I would just give, because the lesion was seen on the surface, the lesion was seen on the cortex, and this sequential photograph will show you that this is the atrium which is opened after the resection. So if you see sequentially, because of we do intra-op ECG, and on intra-op ECG, if I find that there is around dysplasia and spikes, we would do further resection in that area. So ultimately, if you see that I do a post-resection ECG, and this is the area which ultimately needed to be removed to get a ECG silence, and this is the pathology specimen, which was a low-grade glioma along with the FCD. So the lesionectomy here won't suffice. You have to do a ECG-guided resection. And having said that, we found ECG to be very useful. We use it in all cases. It helps us to extend or limit the resection. We avoid changing spikes. So if there is a attenuation to a certain degree, the frequency and the amplitude is acceptable, then we avoid changing the spikes. Now, in the literature also, it is known that it has a positive influence on seizure freedom in the long term as compared to lesionectomy without ECG, but it is not a predictor of seizure outcome. So I won't say that you have to use ECG for a seizure predictor outcome, but it's definitely useful, and people who have used it found it useful, and they continue to use. when I will do a lesionectomy along with amygdalohypocampectomy. So again, if it is anatomically close to the mesial temporal structures, intraop ECG shows intermittent spikes or polyspikes on hippocampus, even if it is not showing on the interictal or the video EEG. Right-sided lesions, we are generous. Right-sided lesions with normal or abnormal profile, we would be very, very generous in removing the mesial temporal structures. Sometimes hippocampal structural abnormalities there, microdysplasias, and whether when the lesion is imperceptibly blending with the mesial temporal structures, then I think we need to take a call. And sometimes most of the things are decided in the multidisciplinary epilepsy group meetings with counseling of the patient. But sometimes we have to take an intraoperative decision when we come out and explain to the patient that yes, we either need to spare the hippocampus, which we had decided earlier to remove, or we need to keep the hippocampus. We need to remove the hippocampus when we had decided that it should have been removed. So these two decision making doesn't end only on the multidisciplinary, but it is carried forward into the intraoperative setting as well. So here are the cases where I would do lesionectomy. We have done with the anterior temporal lobe, where there was a large arachnoid cyst, but this was a completely dysgenetic temporal lobe, which was very, very much perceptibly blending with the mesial temporal lobe structures. This we did an ATL. Left parahippocampal gyrus, the low-grade glioma, and there was a mild hippocampal cortical thickening. Intraoperative, there was hippocampal activity seen and memory was affected. So here, even on the left side, we had the memory affection as well as the hippocampal spike. So we did a ATL. This is a post-op MR where we can remove the tumor as well as the medial temporal lobe structures. Right temporal lobe heterotopia with hippocampal dysplasia. Intraoperatively, there was no activity on hippocampus. There was normal memory. But as I mentioned, that we cannot afford to have a two-stage surgery in a country like India. We have to do whatever we need to do. The best thing, the first shot is the best thing. So normally, I understand that sometimes we need to do this as two-stage and then do more invasive recordings later on. But for us, touch wood, whatever policy or philosophy that we are using has still not gone very wrong. So we are quite good to do a complete ATL in these cases. Left parietal occipital FCD, and this patient had a secondary MTS, and both the things were firing quite well, quite robustly. So here, as this comes in an extratemporal kind of a situation, but here I did the FCD excision as well as the mesial temporal excision at the same sitting. Choroid fissure, epidermoid, again the hippocampus was spiking like anything. Memory was impaired. So here, in addition to the epidermoid excision, we had to do a ATL as well. Here you can see that the temporal the epidermoid has been excised completely, and there is a mesial temporal lobe resection. Right-sided again, amygdalo-uncal ganglioglioma, which I had done lesionectomy only at one point, but since it was right side and memory was impaired, and the hippocampus was not involved, but still we had to do an ATL. Again, bulky hippocampus with memory normal, right amygdalo-hippocampal, parahippocampal gallus lesion, we do a complete ATL. A calcified lesion in the hippocampus, in the middle temporal and superior temporal gyrus with hippocampus was normal, but when we opened the hippocampus, it was spiking. We did a complete ATL in this. We could have done a lesionectomy and then probably waited for the hippocampus to observe the hippocampus in the post-operative period. But again, as I told you, two-stage surgery is extremely difficult in our situation. Sometimes we have exophytic midbrain gliomas coming with status-like situation. So here I had to do a conservative resection of the midbrain glioma, but in addition, I had to remove the mesial temporal structures for control of epilepsy in this in a intermediate grade glioma. Again, superior temporal gyrus DNET, hippocampus normal, but intra-ECG spikes on hippocampus, and we had to do a ATL. Sometimes the the hippocampi are normal or there is a doubtful of a sclerotic hippocampi and there is an extra hippocampal lesion. There's a beautifully demonstrated case that they don't do hippocampectomy, but they do multiple hippocampal transactions with SEEG recordings. And they have found out that as soon as you start transacting the hippocampus from the head to the tail, you find the disappearance of the seizures. So this is a case where probably you don't need to remove the hippocampus if you are afraid of a left-sided or a memory decline or significant memory deficit, where you can just transit the hippocampus. But I don't know what is the long-term outcome in these cases, what happens at 5 years and 10 years. But the seizure control is supposed to be good at 1 or 2 years. So this is also can be propounded. Now, suppose there is a perisylvian insular FCD type 1 with secondary hippocampal sclerosis. This was the patient who had a mild decline in verbal memory. There were 4 to 7 seizures per day. Patient was on 3 anticonvulsants. You can see that there is a anterior temporal as well as insular epilepsy, and you can see that there is a hypometabolism on PET. Here, what I did was I opened the sylvian fissure. This is the abnormal tissue. You can see the vessels around, and I started to do EKG guided resection of the insula till I found that there was a disappearance of the spikes, and I found that the underlying lobe looked normal visibly, and I stopped. And obviously, I completed it with a mesial temporal lobe resection. And hopefully, many a times we have to give the specimen arm block because it helps the orientation for the pathologist. And you can look at the hippocampus, amygdala, and the cortical dysplasia. Many a times the pathologist might report that there is no hippocampus seen in the specimen. So to avoid that, it is better that if we give a complete specimen arm block for the pathologist to inspect. So I would say that temporal lobe surgery is safe in experienced hands. The mortality is less than 1%. As I mentioned, patients do not complain of visual field deficit, but if you are close to the temporal horn, superior rim, you might have a affection of the Meyer's loop. And sometimes, even though patient doesn't complain of 7 visual field defect, maybe about 20% of the patients do demonstrate visual defect on perimetry. Here, again, I can show you a lesion where sometimes you can have an unfortunate incident where there is a spasm of the perforators, or there could be an enhanced signal in the PCA territory, which you need to observe. Many of these patients can have a mild deficit post-op, which continues for 3 to 6 months, and that needs to be observed. Sometimes patients do have persistent post-operative seizures. It's not synonymous with reoperation. Residual hippocampus does not mean resurgery, and sometimes you have to look for an extensive epileptic zone which you have missed, or there could be a contralateral focus which you have missed, or there could be a microdysplasia. So at KEM, we have a good experience of 600 plus surgery, adult and pediatric, temporal, extratemporal. And I just need to mention that we have analyzed our long-term follow-up in more than 10 years in 200 cases where the seizure freedom and anti-epileptic withdrawal was looked at. It is 55 to 60%. So initial outcome, which we had about 80% at 1 or 2 years, dropped down to 60% at the end of 10 years. So all these patients have a good quality of life as regards seizure control and seizure freedom. So here, in conclusion, I would say that early surgery in temporal lobe is advisable if with the neocortical, non-dominant, new onset epilepsy, and it's a progressive lesion. There is a controversy about dominant side, maybe a stable lesion with controlled seizures on single anti-epileptic drug, intact cognition and verbal memory. Non-invasive methods are sufficient to treat most of the temporal lobe epilepsies. Invasive recordings will be required for temporal plus or insular. And I don't undermine the importance of multidisciplinary or comprehensive program, which Jeff has quite nicely elucidated. And quality of life is definitely better than surgery when we have to take the seizure freedom and the seizure outcome measures in addition. Thank you very much.
Thanks, Datta. I think that was a very, very comprehensive tour of the whole temporal lobe epilepsy in children. And I think we have really very little time left. So yes, I would restrict the discussion to comments by Jeff and Brajesh.
I found that talk fascinating, and I did the screen photo of a number of different shots. So I found that talk fascinating. Would you comment on memory assessment in children? Because a lot of times you said memory normal, memory not normal, and that's difficult, right? The tests are not so great. Kids are distractible. Lots of reasons for false positives, false negatives. And secondly, comment on your anesthesia, because you're making very important decisions intra-op, and ECOG's limitations for many surgeons is is it being quieted by the anesthetic? And I'll mute and just listen. Thank you.
Thank you very much, Jeff. I think those are two important questions. Neuropsychological assessment has always been a challenge in children. So in very small children, I would say that yes, they are variable and it is very difficult to get. But older children, we have in our situation, we have adopted a local vernacular paradigm where we have a very robust neuropsychologist, Dr. Urvashi Shah, who is very well known in the field, and she has used her own paradigms to get certain tests, not the entire battery of neuropsychology, but certain tests where it would give us a fair value, where the neuropsychology is really very impaired, or a subtle loss, or a gross loss. So I agree. As in adults, I don't have the objective evaluation in every patient, but we have a fair local vernacular assessment. As to the anesthesia, yes, intra ECOG, I also take it. I'm always very kind of what I could say. I would not take it at face value. So unless the anesthesia, we use dexmedetomidine as a conscious sedation, and we have the BIS monitoring. So the anesthesiologists are fairly conversant with, in tune with us. They take the BIS to 50 to 70, so that I know that the patient is light, not enough light to be awake. And they obviously withdraw the propofol and maintain on dexmedetomidine. So we come from the echo analysis, we come to know that yes, the patient is light and the seizures are coming. But sometimes we do not get any. In fair small amount of cases that we do not get any ECOG. So at that time I have to use the anatomical and the analysis, whether how much to remove, how much not to remove. So that has been a very few, but ECOG experience has been to the tune of about 80 to 90%, very, very useful. We have been using for almost 20 years now, the ECOG. 2009. So 11 years we have been using ECOG consistently. It has been fairly useful.
Both of those reflect considerable experience and dedication, and for which you're to be congratulated and applauded, because that's a lot of work to refine that and get that so that it's good and so that it's useful. And there's a lot of fancy name centers that don't have it as refined as you do.
Thank you, Jeff. Thank you.
Rajesh, you have any comments?
No, I agree with this memory problems, because in children, what happens is when we ask for the drug-resistant epilepsies who have many of them already have a sort of low functioning situation, and it's very difficult to really know whether the memory is affected on one side out of proportion to the IQ and other things. So in general, I mean, of course, the ones who are high functioning, clearly the left side is obviously going to be a problem, and we try to spare it. So I remember one patient who we actually we had a dysplasia which was very close to the hippocampus, but the hippocampus appeared to be normal, and we actually spared it. And I was really worried that he's going to get seizures later, but apparently he remained well. But I think generally memory I agree, is not the main thing which I look at. In fact, most of the patients who do well after surgery, all their scores actually go up rather than down.
Yeah. The scores go down for a certain amount of period because we require long-term monitoring for that. So that is also a challenge, because we see it 1 or 2 years, but I think we need to evaluate this patient for 10 years for the psychology outcomes to really mature. And that has been the literature.
The problem is you don't know what the outcome would have been had he not had surgery. It may have been worse. No? So the whole problem is the kid is actually his own control, and that is it's very difficult to therefore. So you look at it in a group situation, you might find, or compare them to normals, you might find that their functions are obviously less. But you don't know whether those functions anyway would be less because of their drug-resistant epilepsy.
Thanks, Rajesh. Thanks, Jeff. And Eric has had to leave. And Datta, final comments from you before we close.
Yeah, I sincerely thank our international speakers, Dr. Boop and Dr. Jeffrey Blond, for accepting our invitation at short notice. And it has been a very educative, informative, and a very good interactive discussion. Our junior faculty and residents would definitely be enlightened by this talk, and their interest in epilepsy surgery would be more fruitful for them. I thank our panelists, Dr. Rajat Sudani and Dr. Sangeeta Rawat, and for participating in this discussion, and Dr. Chandrasekhar Depujari, whose contribution can never be measured. He has been always at the cornerstone of advancing epilepsy surgery, as well as the literature and everything. So I thank you, sir. I thank all the participants also who are tuned to this webinar for their patient listening, and I hope that this has been a useful discussion. Thank you.
Thank you so much, Datta. Thank you, Shekhar.
Thank you.
Thank you.
Thank you, Jeff. Thank you.
Thank you.
Thanks once again, Jeff, and see you soon.
I hope so. See you all.
Bye.
Bye, Datta.